Hello, good afternoon. Assalamu alaikum. How's everyone? How are you guys? Hi, Dr. Maki. Welcome. Welcome.
Hello,
So,
Doctor.
hi Adila.
Welcome
Hi,
and Ramadan
Anjana.
Kareem.
Ramadan Kareem to you as well and everyone. Hi Yusra, Kuratulan, and we have got a couple of iPhones. So yeah, all the iPhones as well. So we welcome all of you on behalf of MedicoRx. So today we are going to conduct the session with Dr. Maki. So of course I'll be here as well. So later I'll be part of this session as well. Meanwhile, if you guys have any questions, so first of all, congratulations on passing part 2. And then yes, next step is going to be part 3. So I hope we are going to be able to guide you all in the perfect direction. So I hope we are going to be able to help you as well. So over to you, Dr. Maki. So Dr. Maki is here with us and he is going to the held this webinar. So over to you, Dr. Maki.
Okay. Hello for all the participants today. And as you know, after passing the very important and the very difficult part 2 exam, we are just one step to be an MRCOG. So our session today, we will discuss about knowing about your exam and some tips to pass any task and introduction to MedicoRx long course and how we can help you. At the beginning, I want from all candidates to know how the RCOG exam us and how they assess us, how they assess the candidates. There is three levels. Level 1 about the part 1 exam, assessing the basics, like how things work, how the drug work in pharmacology, how the disease occur like in pathology, and how we can do research and interpret results like in statistics. And then level 2, and this is examined by the MRCOG Part 2 exam, and this is for assessing the specialty clinical knowledge. And about Part 3, this is to assess your ability to apply this knowledge in your daily work at the obs and gynae ward, emergency, clinic, operation theater, and labor ward. The idea of the exam is very simple. Are you able to manage a meeting with the patient and solve her problem? Are you able to apply all the knowledge you know to be specialized to a particular patient? This is the idea of Part 3 exam. Do you want to add anything, Dr. Z? Okay. Everyone who is going for Part 3 exam should know that he is an ST5. This is your position. You are an ST5. You should to know that the MRCOG Part 3 exam is a clinical assessment of knowledge, skills, and attitude and competencies. Passing the MRCOG Part 3 exam lead you to be awarded the membership of the Royal Colleague and remain the essential waypoint for the UK trainees to pass from the core training to the higher training. You should to know that you are an ST5. You shouldn't manage every case by yourself. You shouldn't act as a consultant. You should to know your position because it is very important in as a safety point. In part 3 exam, you will be assessed in the 14 modules, which is the teaching, the core surgical skills, post-operative care, antenatal, maternal medicine, management of labor and delivery, the postpartum problems, the gynae problems, subfertility, sexual and reproductive health, early pregnancy care, gyne-oncology, and urogyne. You will have in the exam, you will be assessed in domains, 5 domains, and you should to know that this exam is a domain exam, domain or issue you, so you should to be a domain oriented, not a task oriented. You may get you may pass some domains in the task and you may fail some domains, and at the end you will pass the whole exam. Domains is the patient safety, which is a very important, communication with patient and relatives, communication with colleagues, information gathering, and applied clinical knowledge. So here in this exam, in part 3 exam, knowledge is not the only thing you will be assessed. It is about just 1 out of 5. So don't focus only on the knowledge. Also, you should know that it is an applied clinical knowledge, not just knowledge. So you should apply your knowledge to your special case or your special patient. The exam consists of from 14 tasks, which cover the 14 modules. You will have about 8 to 9 simulated patient colleagues, and one with a colleague in teaching task, and you will take about 4 to 5 structured discussion tasks with the examiner, which is your consultant. Simulated patient colleague, this involves the candidate interacting with an actor. So I want to tell you that you act with a role player. He is or she is a role player, not a real patient. She have a script. She want to go with the script. So please don't ask her in depth. And if the role player tell you about something or tell you about any concern, please follow her concern. In structured discussion, you will discuss about particular topic or particular surgery operation with your consultant or with the examiner. Domains. As I told you, it is an exam of domains, and we have 5 domains. The most important one is the patient safety. If you don't pass the patient safety, you will not pass the exam. So you should to pass the patient safety. You may not reach passing mark in other domains, but you may pass the exam. But patient safety, you must to pass the patient safety to pass the exam. It is very important. About patient safety, how we can develop the patient safety skills, going for the RCOG guidelines on obtaining consent is very important, because in obtaining consent guidelines, you will see the risks of every operation, and it is very important to tell your patient about the risk of any procedure you do, and also you should to tell her about how you can manage these risks. It is very important. Also, you should to know more about the mental capacity and the competence. You should learn the doses and the administration protocol for drugs commonly used in obstetric and gynae. You should to tell your patient when you discuss with her about any drug, about the dose and how she can use it, and also the side effects and how we can manage these side effects. It is very important. Also, you should to know more about the WHO safe checklist. If you boost adult and child safeguarding principle, it is very important. You should to know more about the audit, the incident reporting, the role of the clinical governance. And also, I want to tell you that we know and we believe that all of the candidates in the exam mostly knowing the information, knowing have the great knowledge. they not make it in an organized way. So it is very important to know that you may go uh, and discuss with your examiner or with the role player about any procedure, and you don't tell her about the risks of this procedure. You didn't offer her the alternative of this procedure if this procedure have some risks. So you will lose your safety. You will lose the safety domain, which is a very important domain. So you should to be very organized. You should to be very very organized on telling these things. And also, I think was patient safety, you should to be perfect in other domains. If you was perfect in the other domains, the four other domains, I think you will pass patient safety very easy. Second is communication with patient and family. The key here is to put yourself instead of the patient and asking yourself, is it okay to be treated like that? This is the key to know or to assess yourself. Am I okay in communication with patient and family? So the key here is putting yourself instead of the patient and asking yourself, is it okay to be treated like that? Also, I want to tell you that the lay examiners, the RCOG in the training program for the examiners, they told the lay examiners, please put you instead of the patient and asking yourself, is it okay to be treated like that? So I want to tell you that most of the lay examiners use their they are not objective, they are emotional. So try to be empathetic, try to change your tone, try to take her side, to take the patient side. It is very important. Some we have some things using it may increase your skills, your communication skills, like introduction. You should to introduce yourself, saying your name, and saying the name and the role of you, like saying hello, my name is Mickey, one of the doctors in the clinic today. It is also vital to check the patient name. So you can say, is it, or may I confirm your name and age, please? You should to know that communication is a two-way process. And this is this is very important, because when we starting to discuss about the problem or the disease, we go that we are like we are saying everything without any giving time to your patient to interact with you, without see if your patient is listening well, if everything is clear with her, if she understanding you or not. So you should to know that communication is a two-way process involving listening to the patient and as well giving them the information. You should know about the verbal and non-verbal skills, like verbal like saying things and talking, and also non-verbal like nodding, like open posture, like eye contact. Everything of these things will be assessed specially by the lay examiner. You should to be active listener, show her empathy and emotional response, keeping eye contact, also making an encouraged sound like to indicate you are happy for the patient to keep talking. You should to identify barriers to communication, such as language barrier or disability. You should know that there is no need to apologize for asking if a woman is smoker or drink alcohol. It is written by the RCOG itself. uh, don't say sorry. Do you smoke? Do you drink alcohol? Because it is a very common social habits in UK. You should to follow a non-judgmental approach to the patient concern and decision. You should to use chunks, small sentence, small amount of information, after which you can pause and check the patient understand. But don't say, do you understand me? You can say, am I clear till now? Any question till now? And encourage your patient to ask question. It is very important things in communication skills. And I think practice is very important also to um, to maximize your communication skills. Communication with colleagues. The key point is none or no blaming culture. And please imagine the real situation. And don't forget that you are just an ST5. You are not the consultant. You are not, the one-man show. No, you should to contact your consultant, contact other specialties. You should to also don't undermine your colleagues, don't undermine the midwives. You should to contact the GB. All this is very important in communication with colleagues. Using the SPAR tool is a very important thing, especially in the structured discussion tasks, because going for the task at the beginning of the task using the SPAR tool is very impressive for the examiner. And how we can use the SPAR tool, it is very important, because some candidate saying, I will use the SPAR tool. No, not like this. And some candidates saying the situation is, the background is not like this, but using it in your daily activity. Like when we want to tell our consultant about a particular patient or a particular situation, we call him and we are saying, hello, I have a case of postpartum hemorrhage. This is the first thing we tell our consultant about. Not saying, hello, I have a patient, 33 years old, pregnant, 38 weeks. Not like this. We have a situation. So the situation is the very important thing. So it should, or it must be at the beginning of the consultation or in the calling. So using the SPAR tool, making the situation at the first, like I have a case of postpartum hemorrhage. It is a case of dehydration. It is a case of post-operative bowel injury. And then giving some information in the background, and not all the information provided in the task, just some important information as a background, like her age, her operation, if it is a post-operative, when she delivered, if it is a postpartum hemorrhage. Then going for the assessment. If we have some information about the assessment, like investigations, like examination, so I can just mention some information about this. Or if we don't have and we want to assess this patient more, we can go for assessment, and we can go saying, I want more assessment, or I want more information about this patient, and this is maybe the key to your task, and you can go for the first question in the task and gather the information you want, or you can offer the investigation like the scans and the labs. And then the recommendation. Don't forget about the MDT. And when you tell your patient about the MDT, don't tell her your management will be under an MDT. No, you can, because it is a jargon. MDT is a jargon. So you can say a group of experts or a group of doctors, and tell her about the specialties of this doctor. Ensure that you are understanding the role of nurses and the midwife in the UK, because midwives is a cornerstone in the management of obstetric in the UK. So don't undermine the midwives, especially the specialized midwives and the specialized nurses. You should to practice scenario where there is a disagreement with colleague over care plans, because sometimes, especially in surgery list, is a gynae list, you will see a patient, you don't want this management. Patient is a very difficult for hysterectomy, and she may go for Mirena. So you don't agree about the management. Practice this scenario without blaming your colleague. It is very important. Also, you should not blame your colleagues when you discuss in simulated patient task, in debriefing task, in post-operative complication. You will not blame your colleague who do this mistake, because every one of us will do mistakes. It's very important, and it is very crucial in passing the domain of communication with colleague, and also the safety domain. Information gathering. This is the domain which all of us love, because I think we think that if I speak fluently, so I will pass the exam. And as we know, most of the candidates for the exam are not a native English and are not a UK resident. So we think that if I speak more, so I will pass the exam. No. By this, you will waste your time. You should to know, and the cornerstone to pass the information gathering, to know that relevant question is a question which its answer will help you in the management, directly affect your management. This is the relevant question, because a relevant question will waste your time, and you should specify just 3 minutes for the information gathering and history taking. If you spend more than 3 times, I think you will not complete your discussion or complete your task in 10 minutes. Don't ask mainly closed question. Usually, begin the history taking by an open question. Don't repeat question, and listen well to answer. And you should to know that information gathering is not limited to just history taking, but explaining the investigation, involving and reviewing a clinical incident. If you have a root cause analysis, if you had operation summary, discharge summary, CTG, to get the information from all the provided data, this is under the information gathering. So it is important to know about this. And don't forget that a relevant question, which its answer will help you in the management. It is very important. About applied clinical knowledge. Applied clinical knowledge is very important, but you should to know it is just 1/5 from the domains. 20%, just 20%. You should to know why I focus on that, because you know if you go for a task or in the exam, and you know that this task about gestational thrombocytopenia, I don't know anything about this topic, so I will lose all the domains. No, this is the trick, to know that the exam is a domain-wise exam, domain-oriented exam. So I don't know more about gestational thrombocytopenia, but I can go for information gathering. I will ask here, and I will get information from here. I will ask here relevant question. I will be empathetic with her. I will pass the communication with colleagues because I will contact the consultant. I will manage here under the MDT. I will contact the blood doctor. So I will not lose all the domains. And now, Doctor, hello?
Hi.
Okay. The common pitfalls in applied clinical knowledge, like a scattergun approach to the task, non-systematic approach to the task, and you should to know that non-organized or non-systematic approach to the task, uh, also written by the RCOG in the RCOG training programs for the examiners, that it can make you lose the applied clinical knowledge and also the communication. In order to pass the Part 3 exam, you must be able to interpret the clinical findings and investigation in order to develop a well-organized, specialized management plan to your patient. And now Dr. Zeeb will discuss with you more about the domains.
Yeah, thank you so much, Dr. McKee. Thank you so much. I hope you guys have had a fair idea about, the how domains work in exam. Is there any question so far? Because I can see that Dr. McKee has given a kind of a vast, the knowledge and explanation about every domain. Is everything clear, everyone? Any question? I would just add a few of the points in all these domains. I think that's not going to be that repetitive, but that is just going to summarize whatever Dr. Maki has just, the explained. Is there any question so far? Anyone? Anjana, Asfa, Kurutulan, Sahar, Shahina. Hi, Shahina. How are you? Good to have you back. Hmm. Any question?
Alhamdulillah.
Alhamdulillah, Alhamdulillah. So I think there is no question. So just let me add few of the points in the domains. Like Dr. Maki has just mentioned about domains, that we have to cover all of these domains. But remember, each of the 14 tasks will assess between 3 or 4 domains. You do not have to pass all of the domains, but yes, patient safety is going to be imperative. Communication is going to be there. And yes, of course, it is going to be blended with your clinical knowledge. Once your clinical knowledge is pure, once you know how to talk about any of the topic, then only you can communicate well, right? So any of you guys have any idea that from where are you going to learn about the communication, and how are you going to learn that how to behave, how to talk to the patients? Is there any idea? Anyone? Come on, if you guys are not going to speak, nobody is going to understand that either are you with us here or you are just here to attend the session. That's it. So we do have a couple of, resources to practice from, okay? So I'll be talking about that. And before that, let me just tell you that how to succeed in part 3, okay? So you should know that how are you going to succeed in part 3? And there has to be some strategies, isn't it? So first of all, you have to look confident. You have to appear as a safe doctor. Having said that, safe means that you are, the being professional all the time. You are using, the jargon-free language. You are talking to the patient's level. You are talking to, the extent where a patient can understand you. And of course, then you are going to elaborate. You are going to explain whatever you have, decided for that patient. And of course, the patient safety. Okay, you are not jeopardizing anything which can harm you, your, the colleagues, or even patient as well. Then yes, you have to be logical and you have to be organized as well. And you have to be sympathetic and empathetic as well. All right. So having said that, there is a difference between these two, isn't it? So once we feel for someone, okay, when we can feel the pain, so that's going to be sympathy, isn't it? And when we are going to put ourselves in that situation, and then we are going to feel only, that's going to be the empathy, isn't it? So more and more so, both are going to be interchangeable. But it does not mean that if patient is crying that you will start crying as well. If patient is, the anxious, so you are going to be anxious as well. No, you can simply say that, yes, I understand where are you, the coming from. I understand what are you feeling at the moment. But don't say I know. Okay? Nobody can know anyone's pain, isn't it? So you just need to say that I understand what are you going through. I understand it must be painful. I understand it must be, the causing you any kind of, the stress or something like this. But don't say that I know what are you going through. We don't need to be more, the sweet or anything all the time. The professional. That's it. You just need to be patient. You have to be active listener as well. You just need to use simple and understandable language in a polite tone. Polite tone does not mean that you are going to speak so slow. You are going to arrange sentences and then you are going to speak. Okay? Like Dr. Maki said, that communication has to be there, but not the good English. Okay. So yes, English is necessary, but up to the extent where you can explain yourself, where you can explain your points, and where, you can communicate and you can convey your message. That's it. So nobody needs to pass any OET or IELTS exam just to go for this exam. Okay. Because I do get a couple of, the messages every other day that, do we have to pass OET? Do we have to pass any IELTS test to go for this exam? So the answer is simple, no. Because all of us, know the basic English. So this is what you need to know. And yes, for part 3, because you are going to be dealing with the natives. So yes, you need to, learn, these few sentences, which are okay, to speak. You have to master on, the communication. You have to learn few of the sentences which can be used in the exam as well. Okay? Because in the end, exam station is going to be of just 10 minutes. You're not going to be given an ample amount of time to explain yourself and to take history as well. Then again, you have to change your character and be embedded in the role of a doctor in any specialty at the time of station, right? Because you are going to be, the moving from one station to the other station, all right? So, for example, here is the case of core surgical skills. Here is the case of subfertility. Here is the case of post, the partum care. So you can see that every 10 minutes you are going to change your role. All right, because RCOG really wants all of you to be, the good in dealing with, all these specialties. All right, and you can simply understand it like this. For example, you are in your clinic, you are seeing your patients every day, and you are having, the couple of, the different patients. For example, like I have just mentioned, subfertility, labor, postpartum, and gynecology, PMS, PCOS, PCOD, right? Then you have urogynecology, then you have any of the other patients as well. Likewise, it's same going to happen in your part 3 as well. So you need to change your character from one station to the other station, right? I'm one of the doctor in the fertility clinic today. I'm one of the doctor dealing the post-op round. I'm one of the doctor covering the clinic with my urogynecologist or say specialist in the urogynecology station. So this is how you have to, introduce yourself. We call it as, the situational awareness. Okay. Once you are going to be aware of the situation, then only you are going to be, the good. All right. And on the other hand, you need to be patient, because if patient is going to be talking to you, so you just need to listen to that patient, but you do not allow, the patient to take the extra time. Okay, then you have to interrupt. Then you have to interrupt in the middle, and then you can say that, yes, I understand that you have all these problems, but can I just ask you that which of all these problems are bothering you the most? So you will just shortlist, that's going to be your presenting complaint, right? I'm sure every medical student, knows about presenting complaint, and then we go for history of presenting complaint, then examination, then investigation, and then, the management, isn't it? So the same and the similar thing will happen in this part 3 as well. But of course, because you need to fulfill all these domains, okay? So yes, you have to be talking in the line of all these domains. All right, clear everyone? Any question? Hmm? Any question, guys?
Hello, Dr. Zaib.
Hi.
I have a question here.
Mm-hmm.
Actually, the thing is, I plan to take the May exam for
Mm-hmm.
MRCOG Part 3 if I got a seat
Okay.
in the general seats. So, as you mentioned, that we don't need to cover each and every point in the templates and everything, and definitely that affects our time management as well. So, could
Mm-hmm.
you please briefly tell, like, how much of each domain or how much of each part that Dr. Maki discussed, in all the domains, like information
Mm-hmm.
gathering and
Mm-hmm.
communication with the colleagues and the
Mm-hmm.
patient and everything.
Mm-hmm.
How much should we cover so that we know that we are in the safe zone, that yes, we can go through the station? Because seriously, time management, and sometimes the role players, they will just say something. You
Mm-hmm.
cannot expect them that they will be having those
Mm-hmm.
pre-fed questions that we do while we practice. They
Mm-hmm.
can say anything, and you never know what their speed is going to be that might affect it.
Mm-hmm.
So, how much should we cover to be so that we know that we are in the safe zone
Mm-hmm.
to have passed the station?
Okay, brilliant. So first of all, let me tell you that you as a student are not going to decide that you are, the covering each and every domain in terms of that you need to be thinking all the time that, okay, this is communication, this is this, this is this. No. Once you will practice, you will be in a flow in a way that, yes, you will learn. Okay. So, for example, if you are, the doing, let me explain, give you an example of, okay, let's say this is a case of ovarian hyperstimulation syndrome. Okay, so sweetheart, the one who was speaking to me just right now. So can you please just tell me that what are going to be the history points in the OHSS? For example, if I'm a
Well,
case, yeah, if I'm a case,
yeah,
so what
for
are you
like
going
to
to ask
start,
me?
basically to
Uh-huh.
start, and how I practice generally for my
Mm-hmm.
stations is that we
Mm-hmm.
ask the patient if like she's having any current symptoms. If she's
Mm-hmm.
uncomfortable, we try to make her comfortable. We try to get to know about her current symptoms, just a few
Mm-hmm.
three lines. And then if she
No, no, no.
has the implant.
No, no, no. My question is, what are going to be the important questions? What are you going to ask? As a student, as a doctor, you are seeing me. For example, I'm a case of ovarian hyperstimulation.
Mhm.
Okay, let me give you a situation. I'm with you. I'm in front of you, and let me tell you that I have had the which the IVF. I'm going through the process of
Yeah.
IVF. I have just had egg retrieval 5 days ago, and today I'm
Mhm.
just having the mild abdominal pain and vomiting. So now I'm in ER in front of you. The ER doctor has called you in because you are OBG candidate. So how are you going to proceed with me?
So if it is like for the patient, so we generally start asking about the current symptoms, like you said about the abdominal pain.
So how are
And
you
as
going
she,
to inquire about the pain?
but should I tell you the general or just focused about the pain,
No, no, no.
about the
OHSS.
feature?
I'm talking about OHSS at the moment.
So
Okay.
yes, it
So.
would depend on
Mhm,
her symptoms. Like now you
mhm,
said pain, so about the characteristic, all the Socrates format for the pain,
mhm,
and then a little bit if this she is pregnant and has had it, then a little bit about this pregnancy and how what was done, whether she had the embryos implanted and how much, and about the procedure,
mhm.
and about her
So how
previous
are you going to
yeah.
ask me? How are you going to ask me? That
So
okay,
I'll
my name is
introduce
my
my
name is Ellie. Okay, my name is Ellie, and I'm 36, and I am going through the process of IVF. And 5 days ago, I have had egg retrieval, and today I'm in
Mm.
front of you. I'm having mild abdominal pain. I'm having, I threw up in the morning like twice, and now I'm in front of you. How are you going to dig up the history? Please proceed.
Yes, so it would be like, hello, I'm Dr. Shah in the emergency department. Am I talking to Ellie?
Yes, doctor. Yes, I am Ellie.
Ellie, I can see that you are in uncomfortable. Are you comfortable to talk, or should I give you some
Mm,
kind of
mm,
painkiller?
no, look here, stop.
Mm-hmm.
Once you see any patient with the pain, how do you know that you really need to give any painkiller or no? First of all.
Oh,
So you are
okay.
jeopardizing the patient safety in the beginning. Okay. For OHSS, what is the biggest patient safety? You do not have to give any non-steroidal anti-inflammatory drugs, isn't it?
Hmm.
Right?
Yes.
So if you will ask this just in front of, because you don't know as yet that what exactly patient is with in front of you. So first of all, I mean, not every patient, not every pain needs to be, that comfortable and everything. Please don't blindly follow those, the ready-made templates. Okay. I'm just telling you mild pain. Mild pain might not need any kind of treatment. Okay. Mild pain might not need any kind of anything. I am worried because I'm 36. I am going through the process of IVF. So that's why I'm here because my infertility specialist has asked me to come, whenever I feel all these problems. All right. So, don't, first of all, you can say that, Emily, first of all, my ER colleague has asked me to come to see you, and because you are having some kind of abdominal pain and vomiting. Am I correct? Yes. So, are you able to talk? Are you comfortable to talk to me? Yes, doctor, I am. Okay. So, can you please tell me in your own words, right? This is the one, the closed, the type of questions when you will ask the patient to summarize her own conditions. This is one way of asking questions. We call this at closed technique. All right. Then the second is open technique, because her presenting complaint is what? Pain and vomiting. Okay. So now you have to tell me that with regard to pain, what are going to be the specific points? What are you going to ask about the pain? Now, please proceed.
We need to ask her where the pain is, about the
Mm-hmm.
onset, her
No,
characteristics,
ask
anything
away,
that.
ask away, ask away, ask away. I'm the patient in front of you.
Okay, so Ellie, could you please describe the pain for me?
Yes, doctor, I'm having this pain since last night. Initially, it was very, the mild, but since morning, I'm having, the bit tightness in my lower tummy.
Okay, anything that makes it worse?
Not exactly.
Anything that makes it better?
I just had paracetamol because my doctor has asked me to take that. So, it was just like, okay, but it didn't go away.
Okay, and any other symptoms along with the pain that you're having?
Yes, doctor. I threw up in the morning twice, and it was kind of, the terrible, because now I'm feeling that, I'm a bit dizzy, and I feel that, I need to go to the hospital. So that's why, me and my husband, we came to hospital.
Yeah, okay, Ellie, I will try to address these concerns and will help you with that as well, okay?
Okay.
So, can I ask you a few more questions about your
Yes,
condition?
yes, please. Yes, please.
So, are you having any issues with your bowel and waterworks?
No, but no, not as such.
Okay. And I got to know that you had an IVF cycle a few days back, and there was some egg retrieval and
Yes.
implantation. Is that correct?
Not
So,
implantation as yet, doctor. I just had, the egg retrieval 5 days ago, and my doctor has advised me that I can experience some kind of complication. So I'm just worried that, is there any complication which is happening to me? Is it going to halt my IVF process? Is it going to do something?
Ali, I understand that you are quite distressed, and we are here to help and support you. But could you please tell me a little about the procedure that you had?
Yes, doctor. Actually, I am a case of polycystic ovary. So for the last, the 4 years, we have been trying to conceive, but when it didn't happen, so we consulted our doctor. So he referred us for the IVF. So yes, we are in the process. And because I'm
Okay.
due for this embryo transfer tomorrow, so I'm just, the kind of upset that, what I have, developed, is it some kind of complication? Because I'm having tummy pain. I have had vomiting. So what exactly is that?
Yes, Ellie, I will try to address all your concerns, but I would
Mhm.
like to know I would ask you a few more questions regarding your
Yes, doctor.
condition first to
Yes.
understand it better. And then together we'll try to formulate a safe management plan for you. How
Mhm.
does that sound?
Yeah, that's fine, doctor.
Okay, so then like this, and then I'll ask her about the IVF cycle a little bit. If she's been pregnant previously, a little bit about her
Mhm.
gynae history,
Mhm.
then usual some medical history, surgical
Okay.
history,
Now
ruling
here
a.
I would like to stop, and I would just like to tell you that this is what communication is. This is what
Mhm.
patient safety is. Okay. So the examiner who is going to judge you, for example, if I ask Dr. Maki to judge you, because for example, so he will say that, your communication is okay, you can speak flowy, right? But the thing is that you have to work on your sentences, because if we
Mhm.
will speak like this, so I'm afraid that you are not going to be able to finish your task in 10 minutes time. All right. When a patient is in ER, once a patient is in emergency department, so always understand that you can't be, the fancy all the time. You can't use all these fancy sentences all the time, because that is emergency. You have to deal with that. You have to counsel her. You have to give her management plan. You have to organize, the initial investigations. Okay. Now, if you just, the allow, so just let me tell you that how it is going to work for this patient, for example. Okay. So if I
Mhm.
am a student, if I'm a doctor and I'm going to see this patient, I'm going to ask, her, hello, Emily, I'm Dr. Qureshi, one of the doctor in the OBG department. So my ER colleague has asked me to see you, that you are having some kind of pain and you are having some kind of, the vomitings. Am I correct? Yes, doctor. So Emily, could you please tell me in your own words that what exactly are you having? So doctor, I was blah, blah, blah. Oh, I understand. I understand. Okay. So since last night you are having this pain? Hmm? Yes, doctor. Okay. And can you please tell me the vomiting and how much was the amount? Yeah, doctor, it was, the large in amount and only the water. Okay, all right. So were you okay to, the drink anything afterwards? But doctor, I don't feel like having. All right, all right. And how about your urine? Since the when you have passed your urine, what was the color of the urine and the amount of the urine? Doctor, I passed the last night, and it was bit the small in amount and bit yellow in color. All right. So this tells you the amount of dehydration, what you will expect in the OHSS. Okay. So it means you are covering your applied clinical knowledge, you are covering your patient safety, as well as you are communicating well. Are you there? Are you there? Hello? Because I don't see
Y-
your name. Yeah. So,
yeah, it keeps on coming as iPhone as much as I change it, so I just stopped changing it.
all right. So can I know your name? So
It's
it will be
Vadana Shah. Yeah,
okay,
I'm Dr.
Vadana.
Vadana.
Okay, Vadana. So now you see, because she has told you that I had vomiting. So as a doctor, what you can understand, level of dehydration. Okay. So if somebody is going through this, the OHSS, so ultimately you would, the IVF, so you would ultimately think of OHSS, right? So you would understand, and what is the, the pathophysiology of OHSS? There is going to be, the ovarian hyperstimulation. It will cause, the abdominal pain, bloating, nausea, vomiting, dehydration, and then you have to arrange all these examination and findings, isn't it? Okay. So then how are you going to proceed further? Okay. So can you please tell me that you have told me that you have had these egg retrievals 5 days ago? Yes, doctor. Can you please tell me how many numbers of the eggs were retrieved? Yes, doctor, 25. So now you know, okay, PCOS, one risk factor. 25 eggs, second risk factor for OHSS. So once you will explain the situation to the patient, you are going to be safe once you are going to explain it to the patient. All right. Now you will say that, okay, urine amount, that she is dehydrated as well at the moment, but only in terms of management, you need to know that whether it is mild OHSS, whether it is moderate, whether it is severe. All right. So you have asked all these, the questions. Then you will say that, okay, thank you so much, Emily, for giving me this information. So what I can understand is that you have developed, the complication of OHSS, the IVF, what we call it as ovarian hyperstimulation syndrome. Do you have any idea about that? No, doctor. So this is let me tell you that this is a hyper or the exaggerated response to the IVF medications, and where ovaries will respond more. So I can see that you already have had PCOS. This is one of the risk factor. Then you have had, the 25 egg retrieved. So this is also another risk factor. So what I'll be going to do is that I have to examine you in the presence of chaperone. I have to, arrange some of the investigations. So what investigations? I would like to do one ultrasound. Now examiner is listening to you. He will judge you that yes, she knows, what exactly is going to be the applied clinical knowledge for OHSS. Okay, because on the basis of, the ultrasound, on the basis of biochemistry, you are going to label somebody with mild, moderate, and severe OHSS. All right. So this is how you will say, because so this is how the exam goes. It's not going to be, it has to be flowy, it has to be super flowy. Okay, it has to be, the be fulfilling all these domains. But once you will start, the thinking for everything that, okay, I am fulfilling this, I am fulfilling this, I am fulfilling this. No. Okay. So let me just tell you that even this was my exam case, the OHSS one. And yes, and it is the if you are the okay, your the OHSS history points only, what is the safety point in OHSS, how are you going to manage, how are you going to organize investigations. Trust me, you can pass this station very well. Okay, so once you will say that, okay, I will arrange, I would like to do some bloods on you. Which bloods? I would like to do full blood count. I would like to see hematocrit, which will tell me the amount and the level of dehydration you are having at the moment. Because if the level is increased, it means that you are dehydrated. I would like to check the renal function test, which will tell me the amount of dehydration are you having at the moment. Okay, so this is how you will do. Okay, so if you will say that, perhaps you will get the couple of the information, more information from the examiner, which is going to help you in the making the diagnosis, mild, moderate, or severe. All right. So, for example, if it is mild OHSS, mild, moderate OHSS, then management is going to be accordingly. Okay, Vadana, am I clear?
Yes, Dr. Zabe, this is this is also one of my concerns. Like when you were talking
Mm-hmm.
about the risk factors, and that was
Mm-hmm.
going to be my next question somewhere.
Mm-hmm.
further in the session that when we are talking, perhaps you might address it lately, that when we are talking about, as you explained about the risk factors and like the possible complications as of as in this case of OHSS, that I'll be needing to do these tests to check for this. So when we are like giving the options of say investigation or the options of treatment, so we just need to explain them alongside, like we know that this complication
alongside, okay?
like not category, because this is what I also because some mentors, they say that it's good to just enumerate the complications or what the effect of that the condition might be, and then you can tell about your plan. But you tell about the complication first and then you explain the plan, that
So
becomes
this
a
is
bit
not a breaking bad news. Come on, the anyone who is going for IVF, certainly, the physician, infertility specialist must have told her that, these are the complications that can, they come across with. So OHSS is a pretty, the common complication. Okay. So, this is not something breaking bad news that you have to break the news or something. When a patient is saying that I am aware of that there can be any kind of complication. So doctor, please tell me, is this the complication? Is this the complication which has occurred? Is this something, the bad? Is it going to hamper my IVF? So yes, she is anxious because she already knows. All right. So you will say that, yes, I understand that you are, the pretty anxious at the moment, and this is quite understandable. But just let me tell you that we have to organize some of the investigations, and then only we will be able to understand that what type of, the OHSS you have got, because we have got 3 degrees of OHSS. Okay. So once you will reassure her, so she will understand. Okay. So then you will organize, because remember, at the same time, there is an examiner who is observing you. Okay. And who is going to give you marks on throughout your performance. All right. So once you will organize your, because according to the guideline, how are you going to, categorize the OHSS? All right. See, on the level of, the ultrasound findings, okay, you will see the ovarian size. If it is less than 8 to 12, and more than 12 centimeter, right? And the management is going to be accordingly, right? Mild OHSS can be managed at home. 8 to 12, which is moderate OHSS, can be managed at home plus minus hospital, if the patient do not have any kind of, facility to, they visit hospital quite often, right? And the severe will always be in the hospital. All right. And once you will, they talk about the management, then yes, OHSS, what is the management according to guideline? Pick only 1, 2, 3 important points. What are the important points? Drink to thirst, written in the guideline, right? Drink to thirst. It's not like, and keep herself mobilized, because the chances of development of DVT is there, right? So keep herself mobilized. For pain, what is the pain relief? No NSAID. Again, emphasize that no NSAID. Okay, this will, give an idea again. If you have not mentioned it earlier, so this will give an idea to the examiner that, yes, this is the biggest patient safety point. Please mark my words. If you will, they do every station quite well, but if you will not fulfill your patient safety, which I'm afraid that you are going to jeopardize your whole station. Okay, because guideline has categorically mentioned that no non-steroidal anti-inflammatory drugs. And then you have to explain that why you can't give this, because you already are having, the problem that can compromise your kidney function. That's it. So this is how you are going to explain it to the woman. So what are you going to prescribe her? Paracetamol or codeine? Right? Paracetamol is going to be opioid analgesics, codeine, right? So this is going to be your, and then red flag signs. What are the red flag signs? You will tell 1, 2, 3 only, which are important. Anytime if you feel that you are having, your tummy is getting big, it means it is the OHSS is progressing from mild, moderate to severe, okay? Or if you feel that you are having pain in your lower legs, in lower tummy, okay? Or if you feel that you are having difficulty in breathing, so it means then you have developed a complication, what we call it as, the VTE. Then the third red flag is going to be that, if the vomitings or if the pain is uncontrollable, right? So you will immediately come to the hospital. In the end, you will give patient information leaflet, you will give 24/7 contact helpline. So that's it. So, nobody is going to ask you that you have to narrate your 80-page guideline in 10 minutes time. It's the impossible. But yes, you have to mention at least 2, 2, 3, 3, 4, 4, the important points, which are important. Okay? Got it now, Vidana?
Yes, Dr. Xavier.
Welcome, welcome. So I hope, because this will only come after practice, and once you will practice, and thorough practice is must. And always, they try to understand that how are you going to limit your sentences, how are you going to limit your the time by just the kind of the giving important information first. Okay, even if you have missed something, once you are going to the explain, or if you feel in the end you have some time, that come again. All right, how you can come, oh, I'm sorry, I forgot to ask you, are you allergic to any medicine? Because if you have to mention any medication, and in the history you forgot to ask this, that are you allergic to any medication, so cover it up in the end. So they are not going to cut your marks. All right, so this is you only who is going to modulate how are you going to lead this station, trust me, or any station. Okay, I hope
Dr. Deep, I want to add something.
Yes.
I just want to from you all the candidates to be real. Try to be real. We don't in
Yes.
our clinic, when we discuss any particular disease with our patient, we don't go in our mind or with the patient. We Yes, I will take history now, and then I will tell her about the risk factors, or I tell her about the risks or complication, and now I will give her the management plan. We don't do like this in our clinics or in our daily practice. So in exam also, please try to be real. How you can be real? Yeah, going like at the beginning of any conversation with the patient, we took a history, even a small history, and then when we discuss with her about the management, we can before prescribing medication or antibiotics, we can asking her, do you have any allergy from any antibiotics? So we don't have a special or a template or a fixed template to go to go on it, or to follow it. And also, please, for every candidate, make your own template, make your own sign, because examiners at the exam, they all of them, they told us about how they are getting bored in the exam, because he know 14 candidate, all of you saying the same things, going the same template, follow the same template. So the examiner in the exam don't bored. You want something or someone to attract him. So please follow your own template and build your own template.
Yes,
Give
exactly.
us give us some idea about you and about your personality.
So that's why it is
That's all.
very
Thank you, Dr. Zaid.
no, that is a very the strong and the important point for this exam. So the why we fail. This is another the point. So the reasons to fail, of course, is going to be there as well, isn't it? So failure to have a persistent and consistent daily practice. Believing the myth that the knowledge will not be tested, believing the myth that this is only the communication. So I know many students, I know, the many candidates who think that, they are too good in, the communication, or they are too good in their knowledge, so they can just pass the exam. But no, trust me, this part 3 is all about, the what? It's all about communication skills blended with, the applied clinical knowledge. Okay. So if you will use too many jargons, if you will use too many fancy sentences, so it is not going to give you any extra mark. All right. And yes, try to be, your own self. All right. So don't try to imitate anyone. Don't try to repeat my words. Okay. So you are unique yourself. All right. So don't you just think that if I will, they rely on any particular course or any particular ready-made material, any template, and if I will just, they memorize all these lines and I will just go and I will just pass. Boom. No, it doesn't happen. Okay. So trust me, these days, since COVID, okay, since online, these sessions have happened, and Alhamdulillah, I have been examiner for RCOG as well. So I know, this looks, very bad. Like Dr. Maki has told you that if the 14 candidates will speak the same language, trust me, by the end of exam, I will vomit. And this happens. Examiner do get, the all these nauseated feelings as well at times. Okay. And we have, the many, the colleagues all around the globe, who are examiner now, RCOG examiner, and we do discuss with them as well. Trust me, if you will just rely on, the any course, any material, any ready-made template, and if anybody who tells you that, okay, no, you will just memorize all these 300 plus, the templates and you will just pass the exam, he or she is absolutely wrong. Trust me. Okay. So this might have had happened, the back in 2016, 17, 18, when there were no, the so many online coaching classes and all. I still remember back in 2018 when I was preparing for my part 3 exam, we never had all these, the free sessions, and we never had all these, the courses around. So we just had only, the one or two, the people who were giving us, the good, the guidance. All right. So although those were super expensive, but yes, we never had any choice. So we had to take, the guidance from them. But now today, in today's era, now, the knowledge is everywhere. Coaching is everywhere, right? So you just need to think of that how, by the time you will enter for your exam, so you yourself are going to be the better judge for yourself as well. Okay. So from where you have to take the knowledge, so which mentor is going to guide you properly and with whom you can think that, you can pass this exam. But for God's sake, don't rely on any ready-made template. Okay. So take all these ready-made, the stuff for your help, but not for the exam. Because in real exam, what happens is you might think that this exam question is same. All right. But trust me, they will change the agenda. They will change the marking scheme. They will change the, the task. All right. So don't you always think that, the RCOG is stupid or, they are like, teachers of teachers over there. All right. So who are setting the exam. So never think that, all these questions are repeat exam questions. Like, I do see because I'm teaching for quite long now. All right. So I do see so many, the candidates talking here and there. No, this exam was a complete repeat exam from, the year this. No, you might think that that is a repeat exam, but in, the reality, that is not a repeat exam at all. All right. So again, let me, they repeat it. They might change the task. All right. The question might look, the same. Okay. But they will change the task. They will change the marking scheme. For example, in this exam, my patient safety was, the prime, the important, the point to pass this exam. Okay. But in this, once it has repeated, so they will increase the communication. Okay. They will increase the applied clinical knowledge. Okay. So this happens. So never be, the underconfident, never be overconfident. Just be okay. Okay. Just prepare with your, the own, the pace, and always think that, the how much time is enough? 3 to 4 months study is enough. Nobody is going to study or practice for ages and ages and ages. Okay. So my, the suggestion is going to be that if you really want to go for any exam, for example, May, if it suits you, or November, so just go for it. Don't delay for years and years. Okay. Nobody wants to study for, that long. One thing. Second thing is, once you will go for your exam, so trust me, for example, if you have passed your part 2 now, and if you will go for your part 3 next year, so in this coming year, many guidelines will change. You will have, the many other talk articles. So you will have to study extra. So why not, the go now? And total, I think 3 to 4 months study is enough. Okay. And it is not a good idea to the study for years and years and then go. Nobody can be 100%. Okay. You can just prepare, you can just give your 100% to your preparation. All right. But nobody is 100%, trust me. All right. And the road to success and the road to failure are almost exactly the same. Always remember. Okay. Because the roads are same. The only difference is going to make is correct and the focus guidance into right direction. So choose your, the plan wisely, choose your, the mentor wisely. All right. And this is just going to be a quick recap what Dr. Maki has just mentioned. So information gathering, yes, that has to be history taking. It has to be in order. It has to be crisp and directed towards the case. It has to be jargon free and it has to be focused. And how are you going to learn that? From where you will, learn about the easy phrases. So we have got a couple of patient information leaflet, freely available on RCOG websites. I think they are like 40, 45 plus. Okay. So the rest, all PIL or patient information leaflets can be downloaded from NHS. For example, if you want any PIL, just go to the Google or Safari. Okay. All right. So what you will do that you will just write down, for example, I have to write down OHSS PIL. Okay. Or you can say that patient information. So if any case, if you think that this topic is not available anywhere on the NHS website or RCOG, so you can take help from even the RCOG, the Royal College of Canada, RCOC, okay, or you can take help from RANZOGI as well, okay, Australia and New Zealand. Even you can have the ACOG PILs as well, because English is almost same everywhere. All right. All you need to learn is that how are you going to communicate? That's it. Okay. And even, there are a couple of, the videos available on the YouTube as well. So you can take help from, even when I was preparing, so I took help from, the MRCGP, the videos. Okay. I took help from MRC psychiatry as well. Okay. For some of the important questions, I took help from MRCP as well. Okay. For some of the, the topics as well. So all you need, plus USMLE basis. All right. So you can, take, the help from anywhere. So just observe. How are you going to increase your communication, or you can, make your communication better? Read. Okay, read English newspaper. Listen to the, the English news, BBC News or CNN. Okay, or anything. Okay, and try to understand the accents, different accents. If you will go for UK, trust me, you will face the many different the accents. I have had the opportunity to go for the UK exams. All right, so yes, the Scottish accent is different, Irish accent is different. All right, and the English, of course, the native English, their accent is superb. Okay, so yes, you need to, because being an overseas candidate, sometimes that can be a bit hard to understand all these accents as well. Okay, so improve on yourself. Don't just run after material. Don't just run after the templates and everything, but just improve yourself. All right. And yes, the approach to the patient in a calm manner, look confident, take history properly, ask about the past history, family history, gynecological history, drug history, history of allergy, personal history, socioeconomic history, mental health questions. All right. And how are you going to, increase the communication again? NHS Choices, patient information leaflet, YouTube, Vimeo channels. You can have NHS Choices as well. Applied clinical knowledge, the all part 2 MRCOG, but it has to be applied. Okay, only the important parts. All right. So recommended sources, what are the recommended sources? Guidelines, TOG articles, NICE guidelines, okay, and RCOG website. Then communication, we have mentioned earlier. Okay, communication with colleagues, MDT, all right, consultants, midwife, GP, we don't need to undermine anyone. Okay. Then patient safety, yes, very imperative. Name, age, pregnant before or no, living status, whom do you live with, what do you do for living, LMP, BMI, smear history, safe medications, alcohol, smoking, recreational drugs. But like Dr. Maki mentioned, you don't need to, the signpost. Alcohol, smoking, and yes, for drugs you may, but alcohol and smoking is very normal for them. History of allergy, proper referral, okay? And the most important thing is that don't say any information you are not sure about. So try to be the safe doctor. Remember that, at part 2 level, you are just, the beginner. Okay. You may be working as an independent consultant in your respective country, but for, the RCOG curriculum for MRCOG part 3, you are still a student. All right. So don't just, think of that this is what I will do in my, the setting or in my hospital. All right. So always think that you are a student. How are you going to behave? Okay, what is your domain? Till what you can interfere with the patient and the patient's treatment. Once it is out of your domain, refer. Okay, proper referral is also a good patient safety. So how to start a preparation? Organize yourself, plan, when it is feasible for you, make a comprehensive schedule, look for a good study buddy who is ready to take burden of this tough schedule with you, who doesn't undermine you. Yeah, very important. Okay, and choosing the study buddy again is a trial and error. Okay, So we all are, the professionals, we all are grown-up doctors. So if you think that you can, the match with anyone according to your own circumstances, your time zone, and everything, so yes, go for it. Otherwise, say politely, don't ghost anyone, okay? Politely say no, that, okay, look, our time doesn't match or our energies don't match. So it's a good idea that, we stop discussing here. So don't waste your time, don't waste some others, someone else's time as well. Make your own templates, do all available stations in books, and then at least revise them according to your feasibility. One or two online, the mocks or courses you can, the book if you wish to, and master on communication skills. All right, curriculum we have just mentioned. It's like same like part two. Okay, and from where these are the books where you are going to, the practice your station. Okay. So I hope I did try to summarize some of the Dr. Makki's point. Still, if there is any question, please do ask. Any question, guys? Anjana, Asifa, Hajra, Ifat, Khushbu, Shahina, Yusra, Purutulain, and everyone. Ahmad.
Ahmed. Good afternoon or good morning. I'm in
Hi.
Egypt. I don't know the schedule. Thank you for your lovely information and appreciable information. I have been MRCOG part 2 in last January, and preparation takes about 3 to 4 months for preparation for part 3. If I have only two and a half months, is it enough for me, or I can postpone it for the next November?
You have just passed your exam, my dear, isn't it? This January?
Yes.
Okay. So I would suggest that don't go for this May exam, because already we are like, today is 6th of March, all right? And then 24 days from March, then April, then May. No, I don't think that this is enough for you. Okay. So
Yes.
because this
7.
exam is quite, the costly as well. Okay. Being an overseas candidate, we have to pay a hefty amount in terms of fee and everything. So I would never suggest that you go for this exam, because this time is short, and perhaps, if you will start your preparation now, so if you can
Yes.
study 24/7, then only it can be possible. But I think 24/7 study is not possible for anyone, because we all are working, right? We all are, the consultants or specialists or whatever, isn't it?
Yes.
Hmm.
Yes. I'm a specialist.
Yes.
No, I can't study 24/7. Too much.
I know. So if somebody can put, the 24/7, the effort into this exam, then yes, it is doable. But keeping in view that, the hospital and everything, so I think this is not a good idea. So go for November,
Okay.
but start preparing from now on. Okay? Start preparing from now
Okay.
on, because at least it will take a month or so to get the pace, to know about, the domains, and to all this curriculum, the station. Once you will be in flow, because English is not our first language, right? It will only come with the practice. So you just need to practice. That's it. Okay?
Okay. Okay. Thank you. Thank you very much.
Welcome. Over to you, Dr. Maki. Thank you.
Thank you.
Yes.
Can we have the record of this session again?
Yes. You will have,
Okay.
Ahmad. You will have. Okay?
Sure. Thank you. Thank you.
Welcome.
About your question, Hijra, it's okay to prepare from part 3 practice book along with the leaflet and GTG summary. Yes, it's okay. It is very important to go for the part 3 practice book. But also, I think it's crucial right now to take an online course, because also it is recommended by the RCOG itself. It is recommended for the part 3 exam to take online course about the MRCOG, because he will guide you, mentor you, provide you with the last recalls, give you some experience about the exam. And it is very important also about the study partner. Your study partner is a cornerstone to pass Part 3 exam. This is about how when we can enter the exam. In fact, it depends on you. You should take Part 3 as soon as possible after passing Part 3. For example, if you clear Part 2 in Jan, take Part 3 exam at November, as Dr. Zib say right now. And for who clear Part 2 in July, go for May exam. You will have very enough time for preparing and practicing. Also, you will not forget your knowledge. You're studying for Part 3. And if you didn't pass the MRCOG Part 3, the previous exam, so you should to take the coming exam. How I can begin? Should set your schedule, search for a study partner, because it is very, very, very important to get the study partner or the study buddy. You should to improve your language, preparing your study materials by the patient information leaflet, RCOG, and guidelines, just the summary, recent and trendy talks, practice box, the recalls, strategy videos, and you should to choose an online course and begin. And also, I think it is very important to do a mock circuit before the exam. About improving your lay language, you can go for YouTube and typing patient-centered care. Patient-centered care. Patient-centered care video will teach you more about the communication, and it will improve your communication skills, which is very important also. Here we say some tips and tricks to pass any task in MRCOG Part 3 exam. First of all, you should to read carefully. You should to go, if it is a role player or a structured discussion, know about your domains, your role and position and the place. Read and concentrate on your task and try to be fast reader. Sometimes in the exam, when we read the first and the second line, we found that we know about this task. We know this task. It is a recall. I study it. And we don't continue reading carefully. And we found another task. So it is important to read carefully. It is very important to know about your position, your role. You are an ST5. Where in the ward or in the clinic or in ER, it is very important. You should to read and concentrate on your tasks. Where is the task? Here is the tasks. This is the tasks, because these tasks, the answer key on these tasks, you should to finish these tasks, taking the relevant history, discuss further management plan, discuss her concern. And this is the paper you will find outside the cubicle. They will told you if it is a simulated patient or a structured discussion. They will tell you about the domains you will be assessed in. Here is information gathering, communication with patient safety, applied knowledge. And this is the scenario. There's some information about your patient inside the cubicle, and this is your tasks. Here, they want from you to obtain a brief targeted clinical history, to explain your management plan, and to establish your patient concern. So it is very important to read carefully. You should to know your enemy. I think your enemy is a time. And we have 2 minutes. I think the 2 minutes is the golden 2 minutes. This is for reading. And the first thing to do in the 2 minutes is to forget about the previous task. It is very important because if we have some mistakes or we don't pass the previous task and all of our mind on the previous task, we cannot read and we cannot get the close from the next from reading for the next task. So please, the first thing to do in the golden 2 minutes for reading before going inside the cubicle is to forget about the previous task. Then, if you know the task, try to write anything you know from your practice that usually forget and use your familiar shortcut. So when I practice about ovarian hyperstimulation syndrome, I am usually forget about telling my patient about not to use non-steroidal NSAIDs. So usually I forget that. So I will write for myself in my notes NSAID to remember that. If not, follow your own template and put your plan. In the 10 minutes for the task, in your practice, try to finish the task in just 9 minutes or less if you can. 3 for history taking and six for discussion. Because if you practice to finish your tasks in just 9 minutes, so you will finish in the exam in the real time, 9 or 10 minutes. The main cause of failure is the stress and nervousness, and how we can decrease this by practicing. Practice, practice, and practice. Try not to study the day before the exam. Be calm and don't panic at the exam, even if you don't know the task. It is natural in your practice that you will not know every case you will face. Please be calm, take your history, offer examination and investigation, call your consultant and MDT, and offer another appointment. As you know, as you do in your real life, try to be as natural as possible. Act as if you are in your hospital or clinic. And in the simulated patient task, please forget about the examiner. Don't try to show the examiner that you know a lot of information. You are dealing now with the patient who don't want to know that you have information. Patient just want a reliable and relevant, individualized special treatment for her case. So forget about the examiner. Don't every sentence you look for the examiner. Every sentence you look for the examiner. Try to forget about the examiner and just deal with the patient or the role player. But also think as an examiner. No, every task has its trick. If you think as the examiner, you will pick it. And in your practice with your partner, do one task as a candidate and one as an examiner and role player. This will help you greatly. Sometimes, and some candidates want to play the role of the candidate all the time. No, with your study partner or the study buddy, one time you will practice as a role player and examiner, and this will give you an idea about how the examiner think. And another time, practice as a candidate. Please follow the role player. The role players want to help you pass the exam. You should to be flexible to change your agenda and follow the role player. Knowledge, the cornerstone. So don't stop reading, especially the patient information leaflet, the summaries, the talks, and you should know about your task emotions and the respect the role player's feeling. This is from a lay examiner, real lay examiners. Keep calm. This is the advices of the lay examiner for the exam. Keep calm, maintain a smile, Use short, clear, organized sentence. Self-confidence. They don't love repeated and irrelevant question. Try to explain to your patient her condition in an easy and understandable manner. Help her, the patient or the role player, to take decision. Give patient pro and cons of all options. Reassure your patient throughout the station. Try to do a creative way in breaking bad news and giving solution. Show empathy in a creative way. Give patient time to show her emotions. You should give her or the role player or the patient a clear, organized management plan. Try to improve your relay language by reading, listening to patient information leaflet. As you know, patient information leaflet on the RCOG website, some of them have a recording. So try to listening for this patient information leaflet. Watching video about the patient-centered care and communication skills and breaking bad news. This will improve your lay language and your way in communication skills. And now, Dr. Zib, do you want to add anything till now?
No, it was perfect. It was perfect.
Okay, now this is like what I'm sorry about this, but this is the coming slides from some candidate who didn't pass, and their feelings and how we can learn from this. So you should to know the exam and understand the exam. Most of candidates who didn't pass the exam say that it is a subjective exam. So if you believe that it is a subjective exam, so please impress the examiners and role player. Make examiner ask himself, how can I help this candidate to pass? Not the reverse. How you can make that? By closes, smile, self-confidence, organized, calm, smart, cold, no fear, ready, and have the knowledge. So if you believe it is a subjective, impress me. Impress the examiners, please. Exam is a short film. You should to know that the exam is a short film. And to win the Oscar, you should to be a very real. So please practice, practice, practice. You should to know it is an exam of domains. So be domain-minded. Try to pass domains, not task. Try to search your weak points. You know, 77 this candidate who didn't pass the exam didn't pass the patient safety. So you should search your weak points. And you know, no one didn't pass the information gathering. And only 33 didn't pass the communication with colleagues. 66 didn't pass the communication with patient and the applied knowledge. So patient safety is the most difficult domain for this candidate who didn't pass the exam. So try to search your weak points in domains when you practice with your study partner and also with your mentors. You should to change the way you study and change the plan for preparation. From this population or these candidates, just 66 have a study partner and 33 no. Please, all of you, try to search your study partner and try to have 2 study partners. And also 44 didn't go for online course. Online course is a very important and I think it is crucial. I didn't mean it is paid or free, even. Change the way you study and change the plan for preparation. This is tasks per day. For me, I think you should to spend, you should to take 7 tasks per day, and the months before the exam or the 20 days before the exam, you should to do a 14 task per day with your study partner. And also about the study hours per day is very important. The way you study, regular with study partner, it is very important. And as you know, just 22 from the candidate who didn't pass have a study partner. So study partner is very important and very crucial. And as you see, 44 irregular due to work, some follow course without study partner, some used study material. No one tried to record himself. It's very important to record yourself, and I promise you, you will see how the improvement. And about just 11% mixed between a combination of all of this, who have a regular partner and go for the course. So very low percentage who mix for all of this who didn't pass. Okay, when you practice, I think it is very important to pick a paper and to do one paper for every task. You should to fix it and fill it. For every task, write the important things in your practice. Write the important things about it in one paper and revise it, modify when you listen to the record of the session, or when you revise yourself, or the notes of your study partner. Then you can revise the task very fast before the exam. You can fix template to be filled, like the topic name, history, important things in history, important things in examination, important things in explanation in a language, important things in management, your notes in this task, and how you can close this, and the red flags, and so on. About templates, I'm sorry to tell you that I am against any template for any domain, but we have a structure for the task, the structure for the conversation with our patient. This structure going through the introduction and agenda. And I want to tell you that the coming slides and the structure of this conversation from the Learning RCOG website. This is from the Learning RCOG website. Saying hello. This is about introduction. Saying hello, I am Dr. Mickey, one of the doctors of the clinic today. May I confirm your name and age, please? And then putting the agenda. How would you like me to call you? It isn't very important. I'm sorry about this, but it isn't very important. I understand agenda. I understand from your notes that you have a problem with and you want to discuss about this. Is it right? Any other concern? Give her time to tell you about her concern and to tell you about her problem. And then say here, if you don't mind, I will ask you a few questions for better understanding of your condition. And then we can discuss about the best management option for you. This is an example for introduction and agenda, not a template be repeated with you or by you. About history and examination, you should to know about the aim of patient assessment. The aim of patient assessment is to establish the patient problem and the link between the problem and the clinical finding, to identify the etiological factors. What is the cause behind the patient problem, which may affect the management line? Assess the risk for alternative management, including the anesthesia risk as well as risk of subsequent failure or recurrence. You should know from your history, from the history of your patient, if there is risk for the alternative management. Like if you have a case of recurrent ectopic pregnancy, so we will go for a surgery. But we have a surgery before and salpingectomy. So I have to discuss with her about alternatives. So I will gather some information to know if I will go for medical or I will go for surgery. So I want to assess the risk of alternative. You should to recognize the patient features that may influence the choice of management, such as future fertility plans. You want to discuss with your patient about salpingectomy or about salpingectomy and surgery for ectopic pregnancy, and your patient want other babies, or she don't any baby till now. So there is a future fertility plans. It is very important to explore future fertility plan because this will affect the management plan. In history taking, there are two ways to taking history. The first one is a template for every module, and I think it will spend a lot of time. And if you don't know about the task, you may lose it completely. The second one is the logical way in analysis of the patient complaint. What is the logical way? Ask about the current complaint and open a question. Like, please tell me more about and tell her about the problem. And then analyze this complaint, the onset, the course, the duration, what increase it, what decrease it, and how this affect on her daily activity. And I think it is very important about asking about affection on daily activity. Also, then ask about any signs or symptoms of emergency which need an urgent action right now, like signs of severe preeclampsia or signs of pulmonary embolism. Because if I have a patient with severe preeclampsia or a patient with pulmonary embolism, and I want to ask her about the social life and mental history, and she will die. She will die before I complete the history. And then ask about the risk factors, ask about any condition or disease or special habits which may affect the type of management. Ask about the patient main concern and wishes. I think this is the logical way in history taking. In every task, in every case, in our daily activity and the exam also. Then the management plan is signpost when you finished the history taking by saying thank you for sharing this information with me, and if you don't mind, I will examine you in the presence of the chaperone. And about examination, when you offer your patient an examination, please tell her what you will examine and why. Justify why you want to examine her. And then saying to her, from the information you shared with me, I suspect that we have, and tell her about the problem. And you may reassure her if the condition is curable, or to make a breaking bad news, and give her the option for treatment. At the end, you will summarize and you will close. So what we will do right now, I will give you a patient information leaflet, write back to your GP. I will involve the consultant, tell her about the warning symptoms and signs, the red flags, because it is very important as a safety point, and give her another appointment. That's all for me, Dr. Zeeb. Please, if you have any addition.
No, it is perfect actually. So again, I would like to summarize whatever we have been discussing so far is the practice. Okay, practice is the key for this exam. Doesn't matter, how much do you study, how much do you, take or enroll in the courses here and there everywhere. But if you will not practice, if you will not, the being corrected, I mean, trust me, you are not going to know that where are you in your preparation. Okay, what are you doing, and what are going to be the the points which can improve your preparation. All right, so as a mentors at MedicoRx, me and Dr. the Maki, we both are running our WhatsApp free group as well. You all are the invited to the take part in the daily activities. Okay, so he sends a task on daily basis, and the whoever can send the voice note for the correction. So you all are welcome. Apart from that, we both are the going to start our the long course for the May batch as well, plus the mocks as well. So whoever is interested, whoever wants to be the kind of what you can say, have a focus guidance, you guys are more than welcome to join us. All right. So meanwhile, if you guys have any question, anything, you guys can ask us now or even later as well. Is there any question for me or Dr. Maki? Anyone?
Okay, thank you.
So I think
And yes,
no, I think there is no question. No
yes,
question is also a good question. It means that everything is
yes.
like, okay for them. Okay.
Okay, thank you. And I want to promise all the candidates that we will run a lot of free sessions
Yes.
for practice also.
Yes, we will. We will. Okay. So we will try to, so do like and, the prescribe our Facebook page and YouTube as well. We will be running, the frequent sessions in the coming future as well for May exam. All right.
Yes.
Thank you. Thank you so much, everyone. Okay. Take good care of yourself. Bye-bye.
Thank you. Thank you. Bye-bye.
Ay, naku, Leo. Ano, hito, sir, puff na ng gabantay. What's it